As concern mounts that COVID-19 could overwhelm intensive care capacity in Ontario's hospitals, it's only the latest way in which this pandemic has dominated the delivery of health care. Think of all the tests, treatments, and diagnoses that have not happened due to this emergency. With us now to assess that part of this crisis, and as is our custom, we'll introduce our guests from furthest away to closest to our studio, starting in Kingston, Ontario, with Dr. Chris Simpson. He's the incoming Executive Vice President for Medical at Ontario Health. In Burlington, Ontario, Dr. Jennifer Kwan, a family physician who does a lot of advocacy online around COVID education. In Brampton, Ontario, Dr. Naveed Mohammed, President and CEO of the William Osler Health System. And downtown in the provincial capital, there's Dr. Michael Schul, the CEO of ICES. It used to be known as the Institute for Clinical Evaluative Sciences. He's a staff emergency physician at the Sunnybrook Health Sciences Centre, and we're delighted to welcome all four of you onto our program tonight for, well, let's just call it a very important and timely conversation about all the things that are not happening while we're so deeply focused on COVID-19. I would like to just get each of you to weigh in from around our metaphorical table here on, from where you sit, your particular part of the healthcare system, what concerns you the most about patient care while this pandemic intensifies? Dr. Simpson, start us off.
Well, I think the thing that is most concerning at the moment, Steve, is the extreme asymmetry in the way that COVID is impacting different communities in Ontario. So we see many hospitals in the Greater Toronto area and some other hotspots like Windsor, for example, where hospitals are starting to see significant ramp downs in scheduled surgical and procedural activity, and their hospitals are really filling up, where there is apparently some capacity in other areas of Ontario. So that creates some inequities, I think, that are problematic.
Dr. Kwan, how about you?
Well, as a family physician, I'm getting worried about my patients' tests and procedures and surgeries that may be potentially impacted by the way the healthcare system is being overwhelmed with COVID-19 patients. And I want to make sure that people are still getting the appropriate medical care, including going to the emergency room when they are having a medical emergency.
Dr. Mohammed.
Yes, I agree with Dr. Simpson's asymmetry. The issue right now is the lack of care our patients are getting in every community. I know that Dr. Kwan is working hard in her practice, but a number of family doctors are not seeing patients in person, only seeing them remotely. And some family doctors who are older, due to the fear of COVID, have actually shut down their practices temporarily. And what we're seeing is that the screening for things like breast cancers, colon cancers has decreased significantly. The people showing up in our emergency departments are sicker, and the cancers that we are diagnosing are at a much more advanced stage. So not only is there asymmetry regionally, it's also in the type of practice that you're in and what resources you have to protect yourself.
Dr. Schul, how about your experience at Sunnybrook?
Well, I think we have a very similar experience to what we've heard from the previous three speakers. What I would add is that in addition to sort of a geographic inequity of COVID, there's also social inequity of COVID. So we're seeing particular communities within Ontario that are being much more heavily affected by COVID in terms of cases and adverse outcomes and deaths. And these would include racialized communities, communities with with housing environments that are much more likely to have multi-generational family arrangements living together. And of course, workers who can't work from home, who have to go into work. And that includes a lot of healthcare workers who are being adversely affected.
Dr. Simpson, let's just do a little math here. We are told that 400 intensive care unit beds are currently in use across the province of Ontario. I think we need to know, how many do we actually have, and how many do you think we're actually going to need?
Well, yes, the number of ICU patients having COVID has gone over 400. We're able to model out where it's likely to go with a fair degree of certainty because, of course, ICU admissions and hospitalizations are downstream indicators and are a direct consequence of the new cases of COVID that are diagnosed. So in a sense, what's happening now in terms of the newly diagnosed cases can really accurately predict for us what the next few weeks are going to look like. So some of the modeling suggests that we'll be above 500 by January 24th, which is not very far away. And the numbers, if nothing changes, are likely to go to about 800 by mid to late February. So we have about 2,100 ICU beds in the province. The ICU folks will tell you that about 75% of those beds are taken up by people who just have to be in there. It's unavoidable. So the COVID cases are competing for, if you will, for about 25% of the total capacity, and we're at that point already.
So Dr. Schul, let's just understand this. If we have the capacity of 2,100 and we're only using a little over 400 right now, but we might need double that in a couple of weeks' time, fill in all the blanks for us. What does that portend?
There are a lot of blanks, and it portends a very difficult situation inside hospitals. I mean, I don't think there's any way to sugarcoat this. We're facing a potential crisis within hospitals in terms of the ability to cope, not just with COVID-19 cases, as has been described, but also anyone else. So those ICU beds that are occupied with non-COVID patients, these are patients who've had heart attacks. These are patients who've had strokes. These are patients who have infections that are unrelated to COVID-19 and require ICU care. Those things don't go away just because we have more COVID. And so we're going to need to care for those patients in addition to the COVID-19. So, I mean, the blanks will need to be a displacement of other types of care. So, meaning ramping down any kind of procedures or surgeries for advanced cancers and so on, patients that could end up needing ICU care. It probably means increasing capacity significantly. We've seen field hospitals essentially being built, and I know there's talk of more. It means looking everywhere within hospitals, including emergency departments, to become sort of pseudo ICU beds. And this is far from ideal. And it means that really anybody in Ontario is at risk here, because you don't have to get COVID-19 to be affected. If you're in a car accident, if you have a heart attack, if your loved one suffers from a severe infection and requires hospitalization, anyone who is at risk of that, which essentially is everyone, is at risk here.
All right, let's do a specific example then. Dr. Mohammed, I'll bring you in for this. Your catchment area, in other words, the area that you're basically responsible for, give us the sense of the boundaries. What are you responsible for?
We're responsible for Brampton and North Etobicoke and some of the Caledon area and some of the North Mississauga area. And this is traditionally where most of our patients come from. Okay,
that's a big area, and it also happens to be an area where there has been a rather terrific, and I don't mean that in a good way, I mean that in a big way, a serious concentration of COVID-19 cases. I wonder how many people, do you know how many people have COVID-19 in your catchment area right now?
I don't know the exact number for the catchment area, but I can give you a sense. When people are coming to our assessment centers, which is where people are arriving without symptoms just to get swabbed because they may have been exposed or a family member may have been exposed, our positivity rate right now is close to 25%, which means that every 100 people that are walking in to get their nose swabbed, 25 are positive. And when we go to our cold and flu clinic, which we have converted our ER at Peel Memorial into, the positivity rate is 41%. These are huge numbers. Our hospital right now has close to 170 COVID patients, 20 in our ICU. And without the help of the incident management system, which is balancing out all of the patients across the GTA, without that, we would be in a very difficult situation right now. And I'm really afraid of what will happen over the next 4 to 6 weeks unless things change.
Well, just before I ask you a follow-up question, let's put this in perspective. A 25% positivity rate in your area compares to about I think I saw the number yesterday, at 5% for the province as a whole. So that is significantly higher than the rest of the province. Are you actually able to take care of all of the people who will require help? In other words, do you have the ICU capacity at your facilities in order to meet this challenge?
So I just want to clarify before I answer the question, the 25% is in our assessment center. in our region, the positivity rate is still at 13%, which is more than twice as what is in the province. Do we have the capacity to care for these patients in our ICUs in our hospital? No, we don't. We have been a region that has been hard hit even during the simple flu season in previous years. Without creating, as Dr. Schul stated, other ICU type locations, such as the old emergency department in our Etobicoke Hospital, converting some of our other areas in the hospital into ICU areas, or even renting out some space outside of the hospital to treat the not so sick admitted patients, so somebody that doesn't need an ICU bed. Without doing that, we will not be able to manage. We will need help from other organizations across the GTA and across Ontario, and they have been helping us consistently over the last 4 weeks, and that's how we've been keeping our head above water.
Gotcha. Okay, Dr. Kwan, let me bring you in at this point here again. You work out of a family practice, but I gather that you have volunteered to work at one of the hospitals in Burlington. Give us some sense about what you're up to these days.
So the Joseph Brant Hospital in Burlington has set up a pandemic response unit, which is a tent-like structure outside of the hospital. So it's meant for hospitalized COVID-19 patients who do not need critical care in the ICU, but still need to be managed in the hospital with oxygen, nursing care, things like that. So it is a very futuristic structure with many beds inside and rows with partitions between them. It's very clean. The computer stations have keyboards that are easily wiped down, like it's all flat. So I think it was built with a lot of concern for infection control, especially if all the patients inside will be COVID-19 patients. So I'm still waiting to hear back, but I am on the list to work there soon. And
Dr. Kwan, how close to capacity is that facility? Can you tell when you're in there how close to capacity they are?
So I was in there a few months ago for orientation. At that time, there were no patients inside, but I believe that it has been opened within the last week and patients have started to be brought in.
And if it ends up being the case where they get full, because maybe the experience in Halton region is going to be, picking up in numbers as it is all over the province, what do you do? What do you do when you hit capacity?
Well, I believe this structure is also meant to help with overflow of capacity from other regions, such as Hamilton, because not every hospital has this kind of pandemic response unit. So hopefully we will be able to help manage that from other regions, but I'm not quite sure what will happen if this gets full as well.
All right. Let me read this from the Los Angeles Times from just a few days ago, and this will give us all an idea about what other jurisdictions on this continent are dealing with. Stretched to the breaking point by a deluge of COVID-19 patients, Los Angeles County's 4 public hospitals are preparing to take the extraordinary step of rationing care, with a team of so-called triage officers set to decide which patients can benefit from continued treatment and which are beyond saving and should be allowed to die. The county's top health officials have not yet declared a shift to a crisis level of care, which would trigger the rationing system, but the leader of the public hospitals acknowledged in a letter reviewed by the Times this week that there will likely come a point when we simply don't have sufficient staffing or critical supplies to care for all our patients in the way we normally would. Okay, Dr. Schul, how close are we to that in Ontario?
It's very hard for me to tell you at this stage how close we are to that point. I think we still are a ways away, and I think it's our hope, everyone's hope, any healthcare worker and any Ontarian, frankly, that we may not get to that point. But I think it would be really very dangerous to assume that we won't get to that point, or that we couldn't get to that point, that there's something different about Ontario. Look, what I think is very encouraging are some of the steps that, for example, Ontario Health has taken with respect to looking at all hospital ICU beds in the province as a single pool and transferring patients literally hundreds of kilometers so that they can get the care they need. I think that's a good step. And I think that's something that, for example, wasn't happening in the early days in New York City, when the hospitals were in some cases, competing with each other in a sense, or not sharing resources. So that's a great step. And I think that's one of the strengths of our health system. But the reality is, there is a limited number of ICU beds. There's a limited number of beds that we can pretend are ICU beds. And if we exceed the number of patients who need those beds, whether they're COVID-19 or, as we were saying before, other patients, we will have to make very difficult choices about who gets to be in those beds or be on those ventilators and who doesn't. So this is a situation that we all want to avoid, but I think everyone knows is a possibility here in Ontario, just as it is in LA, just as it was in Northern Italy or New York City a few months ago.
In other words, there's nothing special about us that says we're going to avoid all these other things if we continue to violate protocols and be stupid. Is that what you're saying?
There is nothing special about Ontario. That is absolutely correct.
Maybe I didn't put it so elegantly, but we get the gist of it. Okay. What do we want to do here? Sheldon, I want to go to the graph on page 3 right now, which is, let me take everybody back a few months. This was the surgical backlog created by the first wave of the pandemic when we were under the first state of emergency. And let's go back. This was a study published by the Canadian Medical Association Journal, and it found that between March 15th, the Ides of March, how appropriate, and June 13th, this is 2020, a backlog of nearly 150,000 surgeries was created in the province of Ontario by this pandemic. And the estimated backlog clearance time is 84 weeks, a year and a half. If an additional 717 patients are operated on weekly, with an additional 719 operating room hours per week. So that's going to take some doing. Dr. Simpson, let me get you back in here. Were hospitals able to work through those numbers at the rate once operating rooms opened up in June?
Yeah, it's a very complicated story, Steve, but I think you've got the essence of it. There was a directive from the Chief Medical Officer of Health back in Wave 1, which directed that all scheduled things should stop. And across the province, we saw the rate of surgeries and procedures go down by about 88%. So it was a massive shutdown of so-called elective or scheduled procedures. The ramp back up was quite slow as well. And by the summer, we were sort of almost back up to our usual run rate. And in a few places in the province and for a few procedures, they were able to get above 100% of their run rate. But the backlog was not cleared by any stretch. This time in Wave 2, what we've tried to do is really put a box around the so-called time-sensitive procedures. So cancer surgery is a good example. Some very aggressive cancers that have tumor doubling times of 4 or 6 weeks, it's very intuitive how urgent these are. And we've tried our very best to keep those going. But already in the GTA, we're seeing that scheduled surgeries are down in most places by at least 50%. And we're really just at the beginning of what the next 2 months is going to throw at us.
In which case, Dr. Kwan, let's get a real life example here. Do you have patients who need surgical procedures who are not now getting them because of the COVID backlog?
So for example, even for non-cancer surgeries, say someone has severe osteoarthritis in their hip, that can be a debilitating condition affecting quality of life. They're living in pain every single day, but they were waiting for a surgery date that may have been delayed in the first wave. And in the second wave, there was a constant anxiety about, is this going to happen? Am I going to get pushed back? I'm going to need more medication because I'm just in so much pain and I cannot wait. I don't know when my date is. So they're not imminently dying from cancer, but they are literally suffering from pain every single day from arthritis. Fortunately, this patient I have in mind was able to get their surgery, which is really great. But it depends across the board in different regions regarding the wait times and backlogs. So unfortunately, in some areas that are more severe, I do understand that procedures and surgeries have been canceled.
I genuinely don't want to be alarmist here, but I also don't want to sugarcoat this either. How concerned are you, Dr. Kwan, that you are going to have patients who are either going to get very much sicker or even die because they can't get treatment because the healthcare system is so focused on COVID?
Well, the healthcare system is, triaging and managing those that are emergent or urgent cancer treatments and things like that. But I also want people to understand that the healthcare system is available for you. So if you are having symptoms, you should speak to your doctor. The vast majority of family doctors are open. and are available for in-person visits, especially if you do need to be seen in person. So contact them and reach out, because if you have a condition, you should speak to your doctor. And it's not just the healthcare system doing that. I think a lot of people are anxious about, going out to the doctor's office. Is it safe? And even in my office, I am seeing delayed presentations of medical issues that could have been addressed earlier and, prevented the deterioration. So it's still very important to seek medical care.
Okay, Dr. Mohammed, I'd like to put your health system under the microscope for a moment here if we can. And just so people understand, you don't actually run a hospital, you run a system. So the William Osler Health System consists of what?
It consists of Etobicoke General Hospital, which is a full-service hospital, including an ICU and an emergency department. Our largest site, which is the Brampton Civic Hospital, once again, having one of the busiest ERs in the province. We have the Peel Memorial Centre for Health and Wellness, which has an urgent care center, which is currently our cold and flu clinic, and a lot of ambulatory care processes going on there. We have a withdrawal management center in Brampton, and we also have a floor at the old Humber Hospital called the Reactivation Center. So our surgeries currently are down to 41% of what we usually do. And those 41% consist only of cancer surgeries or emergency surgeries that need to be done right away.
Okay, that's 5 different locations that you're actually responsible for, all told, in the William Osler Health System. And let's do the follow-up question here. How many employees have you got there in the 5 different locations?
If you include all of our employees and contracted employees that work in our organization, we're just under 10,000.
10,000. All right. And I presume they're getting tested all the time. So how many people under your purview have tested positive for COVID-19?
The number of employees that are also employees that have tested positive are just north of 300. Currently, we have 50 active cases of COVID-19 in our employees. The problem with 50 active cases is that each other employee that was exposed to those 50 cases also needs to be off for 14 days. So if you take 7 or 8 employees that are exposed on a unit to one person that may have tested positive, that's 400 employees right now that we cannot access to provide service.
So you've got, on the one hand, it's a good news, bad news thing. By my math, you've only had a 3% positivity rate, which is pretty good. It's below the provincial average, despite the fact that your folks are on the front lines against this thing. On the other hand, you've got a scheduling and human resources nightmare happening here. Is that fair to say?
Well, I think to be clear, yes, we have very strict screening processes. We have very strict personal protective equipment and personal protective processes. The problem is that not everyone that shows up with a symptom of a cough or a cold or a runny nose or a headache tests positive for COVID, but they all have to be off until we can confirm that they're not positive for COVID. Or not everyone that has been exposed to somebody tests positive for COVID, but they all have to be off for a number of days. So it has created a significant amount of issues for staffing. And remember, we need people that can care for sick COVID patients, whether they're in an ICU unit or a step-down unit or in our emergency or a general medical floor. So somebody that may work in an outpatient clinic, near the age of retirement, or somebody that is working doing dressings, they don't qualify for that. So it's those type of nurses that and physicians that we need across the GTA and across Ontario, and that's where the biggest shortfall is.
Okay, I want to talk about fear a little bit here. And Dr. Schul, let me get you into this first. This is no disrespect, obviously, to any of the healthcare facilities that any of you work in, but the reality is any sane person does not want to be in a hospital in this province right now unless they have to be. I'm talking about as a patient. I want to know how fearful, Dr. Schul, the patients that you see are when they find themselves inside a hospital in an era of COVID-19.
Well, I can speak primarily to the emergency department, which is where I work. One of the, so if there are any silver linings, and I think we all need a little bit of optimism. It is the way in which our protocols have changed, the organization of the hospital and the emergency departments have changed to make them safe. So in fact, now if you come into the emergency department and you sit in the waiting room, you're going to sit with a barrier between you and everyone else in that waiting room, and you're going to be physically distanced, and you're all going to be wearing masks. And similarly, as you transit through the emergency department and are encountering staff and so on, we are extremely cautious about COVID-19 and preventing contact, both so that the patient remains safe and that healthcare workers remain safe. And remember that many of these patients actually have COVID. We for the most part, we've not seen huge outbreaks in hospitals. There have been a few larger ones. There was the one in London, Ontario, which I think now is under control, which was very concerning. But I think patients should feel safe. The hospitals are safe, and if you need care, go and get care. And I think the other thing that they should remember is that there are options. So, again, necessity is the mother of invention, and COVID-19 has led to the development or the expansion of virtual options. So, we've seen, certainly in the first wave, a massive increase in primary care being conducted online, as Jennifer was mentioning. 56 times more virtual primary care visits in the first wave than previously. We've also seen the development, for the first time that I know of in Canada, of virtual emergency departments. So my emergency department and several others now provide virtual emergency department visits. So you can go online and see a doctor, an emergency doctor, same day scheduled visits. The idea here is that it not be if you've got a primary care doctor or it's a primary care problem, but for something that you might otherwise have gone to the emergency department, you can get care. And if you need to, the doctor will say, no, you really need to go to the emerge for that problem. So, I mean, it is safe to go to the hospital if you need to, number one, and there are options so that you don't need to go. And I think people should be availing themselves of those.
Well, let's follow up with Dr. Kwan on that. What percentage of your patients right now, Dr. Kwan, are you treating virtually as opposed to in person?
I would say maybe 50-50. So the things that do need to be seen in person would be, for example, prenatal appointments, well baby checks, immunizations for babies, some presentations such as abdominal pain. It's hard to describe over the phone or virtually. So often I will need to see those patients in person, and other sorts of various injections or procedures. So 50-50. The virtual option is actually great for a lot of patients who are scared to go to the office, because we can at least discuss over the phone what may need to be done first. And a lot of especially elderly patients who are worried about catching COVID, that can be quite reassuring for them, and for things such as simple medication renewals.
And if it's 50-50 now, what was it before COVID?
Well, before COVID, we didn't really have the virtual care options. I would still call patients sometimes if it's something simple, but that was not something that was compensated by OHIP. So it wasn't really an available option for most patients. So that has been a positive development in the whole pandemic, that patients have access to virtual care. And I do hear a lot of positive feedback from patients saying that they appreciate the service.
Dr. Simpson, let me return back to that issue of how concerned, how fearful the patients that you deal with in Kingston are when they have to come to you for care. What are you sensing?
Well, I've had the same virtual care experience that Dr. Kwan describes. So in my clinic, it's about 50-50. I try to see the new patients in person, and the follow-ups tend to be virtual. For the procedures that I do, like implanting pacemakers, obviously that can't be done virtually. But even in Kingston, where we've been epidemiologically advantaged, I suppose you could say, and where COVID rates have not been as high as elsewhere, there still is that same fear. And we saw in our emergency department in wave one, dramatic decreases in the people coming in with heart attacks, for example. I'm a cardiologist. And it's not that those heart attacks weren't happening, they were happening at home. And now, as Dr. Mohammed said earlier, we're seeing later presentations of disease, more advanced cancer. Instead of coming in with a heart attack, people are now coming in with heart failure, the downstream consequence of a heart attack. So even in places where COVID has not been as high, in incidence and prevalence. The fear is the same. And I just really wanted to echo the message. I feel safer sitting here in my hospital office today than I do at Costco. The vast majority of transmission is happening in the community, and with the notable exceptions of some outbreaks in hospitals are safe, and patients who need to be here should still be coming.
Let me do a follow-up on that, because that's a great point. We have heard that because the province has, in its wisdom, decided to shut down basically all the small businesses in the province, people are packing places like Costco and Walmart and the other, big box superstores. Is that a good idea in your view?
Well, I think, the way that I look at it is that COVID is going to spread to whatever extent people are in contact with each other. It's a simple sort of statistical reality or fact that the more one human is in contact with other humans, the more COVID we're going to see. So measures that are taken to reduce the number of people in contact with each other is going to be the only way that we can reduce COVID numbers going forward.
I get that, but by telling people they can't go to small business locations where the numbers might be smaller and where the measures taken can be more intense to keep people apart, in other words, no more than 5% typical capacity in a small business at any one time, because we're not doing that, people are literally just descending on the big box stores in huge numbers. That's not keeping people apart. Is this policy working, I guess is my question.
I guess the numbers will ultimately be the judge of that. But exactly as you say, well-intended policy that then results in unintended consequences that results in more people being in contact with each other will invariably lead to higher transmission rates. There's no doubt about that.
Okay, we're down to our last few minutes here, and I'd like to give each of you, 45 seconds or so, just to give some advice to the people watching this right now. You have all outlined what the future looks like if we don't get our act together. So Dr. Kwan, go ahead, be the doctor and give us some advice right now. What do we need to do in the next little while?
So I just want to reiterate that, if you're having an emergency, you should go to the hospital. I get calls from patients saying, well, I had severe crushing chest pain yesterday and I couldn't breathe and I felt like my heart was pounding under my chest and I was going to pass out. But I thought I was having a heart attack, but I didn't want to go to the hospital, so I'm calling you. But the next day, that's not going to be helpful because if you were having a heart attack, you could be dead by the next day. So you should go to the hospital when you think you're having an emergency. And the second part is that I also want to advocate for, ramping up of vaccinations across the board in Ontario, especially for our frontline workers and for people who may not have access outside of the hospital system. I'm hearing a lot of people, even ER doctors working in rural areas saying they do not have access to the vaccine yet. So I'm hoping that will be changing in the next days as soon as possible because, many doctors are still working with COVID-19 patients and do not have protection. So hopefully, we will see the vaccinations ramp up.
Okay, I have an eye on the clock here and we don't have that much time left. So Dr. Mohammed, if I could get your advice and a little more economically, if I can say that.
We're not going to fix this problem in the hospitals. In the hospitals, we're only going to deal with the results of it. Please stay home. Please follow directions. Please stay out of the stores unless you need to go. Please do not travel, and please do not gather socially. Thank you.
30 seconds to Dr. Schul, 30 seconds to Dr. Simpson. Go ahead, Michael Schul.
I would completely agree with Naveed on the need to follow public health guidance, to not tire of these restrictions. We are all tired, but we need to follow the guidance of public health and get vaccinated as soon as you're eligible and the vaccine is available to you.
Last word to Ontario Health.
Well, I would simply say, that this isn't just about looking after COVID patients. It's about protecting our health system for every Ontarian. And this is a chance for every Ontarian to take an active role, exercise their civic responsibility to help protect our healthcare system to everyone's benefit.
Doctors Simpson, Kwan, Mohammed, and Schul, we are really grateful you could take time out from the very valuable work you're doing to spend some time with us on TVO tonight and help out our viewers and listeners as well. Take good care, everybody, and thanks so much.
Thank you.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.